Well, first of all, I would like to say hello and thank to Global Power of Oncology Nursing for the invitation to share this space with you. Also, I want to introduce myself. I am Lourdes Ruda, psychologist and psychotherapist, professor at Pontificia Universidad Católica del Perú, and foundational member of the Peruvian Psycho-Oncology Association. Today, I will talk about the mental health of the oncologist adult patient in the context of COVID-19 in Latin America. I must say that in much of the presentation I have taken the case of Peru as a reference, knowing that many of the countries in the region share a series of problems. However, it's clear that not everything is extrapolated. Before entering fully into the issue of mental health of cancer patients in the midst of the COVID-19 pandemic, I think it's important to give an overview of what it has meant in health systems in Latin American countries, taking Peru as a point of reference. Given this context is essential because these conditions have overloaded and increased the affective impact that a person with cancer has to deal with. We will then begin to remember that cancer patients are a very vulnerable group in the pandemic due to their immunosuppressed state caused by both cancer and various anti-cancer treatments. We have thus that comparatively the lethality of a patient with cancer is 6% versus that of the general population that corresponds to only 2%. This increased risk of cancer patients is evidenced by some statistical figures a few months after the pandemic started. Of the patients who had some type of comorbidity when contracting COVID, 14% died. Cancer thus ranked second in mortality due to comorbidity after chronic lung and bronchial diseases. Considering that, which was the COVID impact on oncological care, what decisions needed to be made? It's precisely for this reason worldwide formulas had to be designed for the care of cancer patients. The ongoing challenge is balancing the risk of hospital admissions with the possible risk of a SARS-CoV-2 infection. In most of the world's health institutions, some practices or protocols had to be renounced and priorities established. Thus, strategies such as reduce the number of patient visits to clinics and increase in teleconsultations, shorten the fractionation of radiotherapy, convert systemic intravenous therapy to oral, delayed in starting treatments and surgeries, and stop or reduce the frequency of select treatments. At the same time, controlling the possibility of contagion with COVID-19 through permanent tests to the staff, patients, and the family. It also reduces the possibility that the patient is accompanied for consultations and when he is hospitalized. In this regard, it's clear the correlation that this has in the mental health of the patient. To these restrictions, others were added that had to do with the urgency of response to the great problem that the pandemic is imminent, with the resources of each country and the particularities of their health systems. In the case of the region of the Americas, for example, the attention was limited to 61% of cases because a large proportion of medical staff had to be reassigned to respond to the COVID problem. Another complicated decision was the suspension of screening. The consequences of these decisions begin to be seen in the figures of death from cancer or diagnosis of cancer in advanced stages. In Peru, as in many countries, there was no adequate planning regarding the pandemic. We went from being the country that declared absolute quarantine earliest in Latin America, if judged by the number of cases diagnosed when that measure was taken, to becoming 2 months later the second country in the region with more COVID cases in absolute terms after Brazil. Meanwhile, Peru was fighting with the crisis about pandemic. Then it started a political crisis. President Vizcarra is removed and a transitional government is installed between November 2020 and July 2021. At that moment, the new President Castillo takes over. In the midst of it, there was a very short vision with the coronavirus. all the effort went to the pandemic and other important diseases were put aside. This resulted in very radical restrictions on patient care and administration of treatments, even in specialized centers. A survey applied to 660 cancer patients between the second half of March and the end of May to cancer patients reported 70% rescheduling or canceling medical appointments, 62% delays in treatment, care, or delivery, 48% health was aggravated by delayed attention, 6% treatments, access, and delivery of medicine, and 92% presents difficulty receiving prescriptions virtually and attending the hospital. The problem was greater for people living in provinces because Peru has a severe centralization of services. Because of this, half of 66,000 Peruvian cancer patients had to be treated in Lima and assume the cost of travel and accommodation. Unfortunately, as we all know, crises lead to the existing structural gaps being even larger. The decision to suspend domestic travel for 14 months severely affected access to treatment. So, 95% of patients had difficulty receiving their treatments and versus 42% that live in Lima or Callao. Another aspect that has been clearly affected as a result of the pandemic is the economic dimension. As shown by the data from the Esperanza NGO survey to which we alluded previously, in this case, it informed that only 21% accessed some government help, 10% of family heads lost their jobs, 26% cases a family member on whom the patient depends financially lost their job, and 95% of those who incur out-of-pocket expenses costs have a high impact on their finances. After approximately a year and a half of the pandemic, studies are beginning to reveal some figures that reflect the consequences of these limitations in the care of patients with cancer since March 2020. The first complex problem that is revealed is the difficulty that occurs to maintain an adequate record of the population served. This makes it difficult to accurately measure the magnitude of the existing problem due to the reduction in attention. A significant number of cases do not have histological confirmation or clinical stage recording, as the methods used for diagnosis have shown limitations for this. Cancer care decreased by 37%, and cancer deaths during the health emergency have increased by 31%. In this chart, we can visualize the impact of the pandemic on cancer. Death increased by 30%. Because of this, more than 21,000 unrealized care, which reduces the number of diagnoses and assumes that patients will arrive with a more advanced cancer, which increases death in the medium term. More than 81,000 care not provided to patients in advanced stages of the disease, which explains the rise in the mortality rate during the pandemic. This year, the increase in consultation has been significant. It has even reached the highest figure in the last 5 years. This, however, is due to the general hospitals in Lima and regions continue to meet the demand of COVID patients until now. All of the previously exposed only seeks to contextualize what we already know is the complex reality of the cancer patient in this context, the stressors that are added to it, the experiences that this brings, and the resources that they have to deal with and the situation that they have to live. But what information do we have about the mental health of the cancer patient in this period of the pandemic? Although it's clear that cancer patients in this context of a pandemic more than ever require psychological care. At the beginning of the pandemic, professionals in Latin America saw their activity significantly reduced. FIPOL, as a training and research group in psychosocial oncology of which I am pleased to be part of, prepared a study in this regard. It shows that the care that was reduced the most was outpatients, installing teleconsultation as an alternative form of care. In the case of Peru, there was a significant delay in the implementation of psychological care for patients that had to do with the decision to reduce the number of professionals attending the institution, and the reassignment of functions. Many of them dedicate themselves to the care of family members of COVID patients and others to offer emotional support to frontline staff in COVID care. This is how the survey of Esperanza indicated that only 1% of those surveyed obtained support of this type through online platforms. Only 57% indicate feeling depressed, and 99% indicate that they require emotional support from a specialist. Months later, we see with hope that the National Institute of Neoplastic Diseases reactivates the care of patients since February in the modality of teleconsultation. It's disturbing, however, to note that mental health has the last place in the priority when it comes to the care of the patient with cancer. We believe that to account for the experience of patients at this stage, it's a special value to listen to their direct voice. Because of this, in the wake of this conference, I asked one of my patients if he could summarize what it had meant for him to continue his care in this time of pandemic.
Sometimes being the protagonist of a disease like this makes us travel to a world of fear and uncertainty, where only those of us who unintentionally get this train ticket know how hard it is, where a deteriorated health system involved in bureaucratic procedures creates an uphill road, and without any contact, we sink further. My name is Diego. I am 29 years old, and I was diagnosed in 2019 with stage 2 classic Hodgkin's lymphoma. I am Venezuelan. I have a degree in disaster management, and I came to Peru, like many of my compatriots, to forge a better future for myself and my family, a future that I could not find in my country. Here, I have not hesitated to work on what is offered to me, and I dedicate my work to a company making deliveries. First, I must be grateful to this country, because having returned, which was in my thoughts after learning about my illness, I would not be here at this moment with a life expectancy that daily feeds my faith. Going through this disease is painful, exhausting, both physically and mentally, and above all, expensive. In such a neglected and worn health sector, where empathy and humanity should be paramount, unfortunately, we did not find it. We stumbled on a callousness on the part of those who should be our protectors, regardless of the need or pain that present at that moment. Where being treated by different doctors is part of the day-to-day. Where seeing a new face of your doctor implies having to tell everything from the beginning, running the risk of taking an incorrect action that alters the healing process. Where the saddest and regrettable and painful thing is many times, health professionals do not even see your face, particularly when there is bad news, when there is no favorable response to treatment, and there are doubts as to whether it can be offered to you. Another even more so when you do not have the financial resources to opt for a more sophisticated one. To this worn out sector, we were joined by this global pandemic of SARS-CoV-19, which not only affected physical health, but also our mental health. Cancer, like other pathologies, is not a disease to which I can say, wait, COVID-19 has arrived, do not advance. On the contrary, stress, despair, anxiety, impotence fed the disease more and more. It was like a car moving at 1,000 miles an hour, and then you realize you're screwed. What this pandemic has achieved is to aggravate the situation of vulnerable diseases to a situation of emotional, social, and health fragility, where time stopped for many, where dates were postponed, diagnostic tests were delayed, vital treatments were suspended, both chemotherapies such as radiotherapies were postponed for dates that for many of us were distant. They were endless days, and in the worst of the cases, these dates never came for some.
A study on the concerns of cancer patients in this period, assessed from the perspective of mental health specialists in Latin American countries, reports that the main concerns they observe are exposure of themselves and their relatives due to the possibility of contagion that this involves and the risk of death that this entails, limitations and delays in their treatment for cancer due to COVID, not being able to receive adequate medicines and poor care at home, fear of breakdown and being alone, and difficulties in accessing telehealth. Although there are few studies of cancer patients in the context of COVID-19, they inform us that in clinical terms, the anxiety and depression levels of the cancer patient during the pandemic have risen compared to those of the pre-pandemic. In this way, it's reported a significant number of patients achieve medium and high clinical level of anxiety and depression. Some authors also find difficulties sleeping, hostility, and post-traumatic stress. Research also reports various protective and risk factors that I have estimated to rank in various groups of variables. The first one is social demographics. It means that being female gender, being single, having a complex economic condition, and living in extra-urban areas act as risk factors, and that their inverse qualities become protective factors. The second one is psychological. It means that having pre-existing conditions of a psychological distress acts as a risk condition, while being a person who uses the resource of humor, for example, and has a network of family and friend support constitute protective factors. Then we have health and well-being. The perception of low quality of life is associated with more risk of mental health, while sleeping well favors it. About cancer variables and its treatments, uh, we find that high levels of pain and fatigue and patient-reported immunosuppressions, as well as delays in care, act as risk factors. On the other hand, being receiving treatment and or having a longer time of diagnosis are protective factors. Then we have link with health institutions. The low confidence in the institution and the assistance through teleconsultation are reported as risk factors. Instead, satisfaction with the staff and trusting in the information of the doctor reports as act as protective factors. Finally, regarding the variables associated with COVID-19, explain that those patients who are very exposed to news of the pandemic and are more afraid of it have greater risk of presenting difficulties at the level of their mental health. However, being informed about the pandemic but not overexposed to news acts as a protective factors. Knowing all this regarding the mental state of cancer patients confirms the already anticipated need to offer psychological care services to cancer patients and their families, and to find ways to reach them. Despite the fact that at the beginning of the pandemic, mental health services significantly reduces care. Then, countries around the world, including Latin America, have opted for teleconsultation. The achievements have been important, but professionals consider that they require further training in this regard. However, it will be necessary to address the variables that are identified as limitations in this type of service offer. Finally, after all the above, we have the following conclusions. The first one is the pandemic has increased the stressors they were already facing in cancer patients, like fear of death grows exponentially, and isolation is no longer just for the patients but generalized, and that leaves them lonely with fewer possibilities for company and protection. Fear of not being able to access health systems to receive care, and going to a hospital means assuming the risk due. And the second one, it's a patient's right to receive psychological care as a part of their comprehensive care and a duty of the state to offer it, like vaccination of cancer patients and increases staff and face-to-face care. Also, teleconsultation was an alternative that can continue to be used, especially in countries where there is a shortage of professionals outside the